Assalamualaikum and hello everyone. Today I will be presenting a clinical case study on amyotrophic lateral sclerosis, which is commonly known as ALS or Lou Gehrig disease. This presentation aims to help us understand the pathophysiology, clinical features, diagnosis, management, and psychosocial impact of ALS through the lens of a real-world patient scenario. Now I'm going to start with the background on ALS. So amyotrophic lateral sclerosis is a progressive neuromuscular disease that involves the neurons responsible for controlling the voluntary muscle movement. ALS most commonly appears between the age of 55 and 75 but can impact individuals with any age group. In ALS, both the upper motor neurons and the lower motor neurons degenerate and therefore stop sending signals to the muscles. This interruption in signaling results in weakening of the muscles, twitching known as fasciculation, and muscle wasting. So there is 6 pathophysiology of ALS. The first one is glutamate acidity. ALS patient will have impaired glutamate reuptake due to malfunction of the EAAT2 transporter on astrocytes. This will lead to glutamate accumulation, overactivation of glutamate receptors, especially NMDA, and calcium overload in neurons, causing cell death. The second one is the oxidative stress. In familial ALS, mutation in SOD1 superoxide dismutase 1 will reduce the cell's ability to neutralize reactive oxygen species ROS. Accumulation of ROS will damage the protein, lipids, and DNA, promoting neuron death. The third one is the protein misfolding and aggregation. Misfolded protein like TOP43, FUS, or mutant SOD1 aggregate in motor neurons. This inclusion will disrupt the normal cellular processes like RNA metabolism, autophagy, and axonal transport. The next one is mitochondrial dysfunction. Mitochondria in ALS neurons are swollen, fragmented, and energetically inefficient. This will contribute to apoptosis, impaired axonal transport, and energy failure. After that, neuroinflammation, microglia and astrocytes will become activated and release pro-inflammatory cytokines such as TNF-beta, alpha, and IL-1 beta. This will contribute to neuronal injury and accelerate progression. Lastly, RNA metabolism dysfunction. There will be abnormalities in RNA binding proteins such as TDP43 and FUS impair RNA splicing, transport, and stability. This will disrupt neuronal protein synthesis, especially in axons. Now I'm going to talk about clinical case. So our patient is Mr. A, which is 58 years old, retired school teacher. He initially noticed weakness in his right hand, making it difficult to write or hold objects. Over 6 months, the weakness progressed to both arms, and he began to experience slurred speech and difficulty in swallowing. For the history, there is no sensory symptoms, no bladder or bowel problems, no family history of neurological disease. On examination, muscle atrophy was visible in the hands and the forearms. Fasciculation were noted in the tongue and the limbs. Reflexes were brisk, and Babinski sign was positive. Lastly, his speech was slow and nasal. The diagnosis that Mr. A underwent is EMG, which is electromyography. We show the denervation and fasciculation in multiple muscle groups. The next one is MRI of the brain and spine was normal, ruling out compressive or structural lesions. And then Mr. A also underwent a blood test that were done to exclude B12 deficiency, autoimmune disease, and thyroid disorders. For the management, Mr. A was started on some medications such as riluzole, a glutamine inhibitor that prolongs survival by a few months, and the second one is endarafone, which is an antioxidant that helps slow functional decline. And then a multidisciplinary team that was involved. The first one is physiotherapists that help to maintain joint mobility and reduce spasticity. Speech therapists who assist with swallowing and communication. Dietitian who support his nutrition and his he later also received a PET tube for feeding. When his breathing worsened, he was given a BIPAP support at night. For the prognosis, ALS has a poor prognosis. Most patients will survive 2 to 5 years after the diagnosis and often dying due to respiratory failure. However, some patients will live much longer. A famous example is the Stephen Hawking, who lived for decades after diagnosis. Factors that predict better survival include younger age, limb onset, as opposed to bulbar onset, and early access to care. For the psychosocial impact, Mr. A experienced grief and anxiety as he lost his independence. His wife became his full-time caregiver and their children struggled to cope. Psychological support, counseling, and spiritual care become essential. He also connected with the ALS Association for resources and emotional support. It's important to remember that the mind often remains sharp even when the body does not. In summary, ALS is a progressive neurodegenerative disease of the motor neurons. It presents with both upper and lower motor neuron signs. Diagnosis is clinical, supported by EMG and imaging. Management is supportive with medication like riluzole and endarafone plus multidisciplinary care. It is a terminal illness, but compassionate care can greatly improve quality of life.